talk will be on macro trends in health IT. This is because I've been in this industry for about 3+ decades now, and so I'm going to try and give you the forest view rather than the tree view of what's been going on in the industry. I'm now in private consulting. I retired from a full-time position about 5-6 years ago, and I work both privately, independently, and I also work closely with a global consulting firm called LEK, which is based out of New York City. So let me just get the slides here. So my most recent role, I was a board member at Spoke, which is a NASDAQ-traded health IT company. I was there on their board for 9 years. Before that, my full-time position was as president of what is now a division of Philips Healthcare. It's called Vital Health, and we developed a EMR platform as a service, and we also had applications built on that platform for chronic disease management and routine outcome reporting and patient-reported outcomes. Before that, I was at GE, General Electric, was a vice president in their eHealth division. I was there for about 9 years and worked initially in their imaging division and then moved into the eHealth division, where I oversaw a lot of international projects during the time of national eHealth initiatives beginning all around the world. So I'll have a little more insight into that later. Prior to that, I was with a leading imaging company called Vital Images, now owned by Canon. And that company was probably the first to introduce three-dimensional medical imaging technology to be an adjunct to PACS systems. So there are 4 major health challenges that we're seeing globally, and especially here in the US. I can call them diseases of healthcare. One is rising costs with aging populations and chronic disease. Another is inefficiencies in the healthcare system, difficulties in scheduling and payment, way too many faxes, still too much paper. Despite all of the progress, it's not as electronic as we would like it to be. It's not as instantaneous as it should be. Another disease of the healthcare system is lack of access. Way too few doctors, particularly now with the pandemic. A lot of people have left the profession in order to avoid burnout. And especially this is true in rural areas where technology has been stepping in to help and bridge that gap by exporting expertise through telehealth and so forth into rural areas. Another major issue or disease, we could say, is the quality of healthcare. Too many times patients are being treated with incomplete medical histories being provided to the caring provider, medication errors, and as we've heard from other speakers here today, just human error is an issue. So treatments that are being tried for this, one is digitization of health information, recording health information electronically, and then the next is sharing that information through a longitudinal electronic health record, allowing data to move between existing systems. Another treatment is disease management. The highest costs of healthcare in the system are chronic diseases, and with aging populations, this is becoming more prevalent. So there are attempts to right-site care with home health, patient-centric devices, etc., to lower the costs and keep patients out of the hospital and out of the physician office. And then finally, consumer empowerment. And this would include personal health records and other technologies that enable individual patients to take charge of their health and be proactive in managing it. So in terms of the systems that exist, I'll give a little bit of the history for those who may not have been around as long as I have. So the first systems that came out were really the ADT systems, which stands for Admission, Discharge, and Transfer. This was the master file of patient identity, contact information, and other very simple key data. And these systems replaced the paper files, which had been used for generations prior to that. Then after the ADT systems were in place, the next which really emerged for clinical solutions were hospital departmental systems, particularly in imaging or radiology and laboratory. And these started commercially in the 1970s and began to evolve much more rapidly in the 1980s and then the 90s. However, these were still standalone systems. They were islands of care, you could say, that were not networked. There were no networks in that era, so they could not share data. For example, the first imaging display systems, or picture archiving and communication systems, normally abbreviated as PACS, those were tethered directly to the MRI and CT systems, and they could only display the images they were collecting on that system. They couldn't send them anywhere. They couldn't import them from anywhere. And then after that, other departments, such as the blood bank, cardiology, etc., began to digitize and also adopt their own version of standalone systems in their departments. Then the next thing that happened was consolidation and then competition. As networks became more developed and the desire to share information grew, tension began to arise between what we would call these best of breed systems, which are these individual departmental systems that were standalone, and these early generation enterprise systems, which were enterprise systems, as the name implies, were designed to serve multiple departments and not just one. The trade-off that was faced in the era was best of breed systems. These individual standalone systems were highly optimized for the specific needs and workflows of the department for which they were developed, while the enterprise systems had the advantage of having a common single database architecture and a common look and feel user interface, and they could therefore also share data between their modules and across departments. So in this era, hospitals landed on one side or the other of that fence, either best of breed or enterprise, depending on who was calling the shots in the procurement cycle, whether it was the chief financial officer, the department chair, chief medical officer, or the CIO. However, as you might expect, eventually enterprise systems won out. This is very similar to what we saw in personal computing with Microsoft Office, which replaced a lot of individual applications that many of us used in the early years of computers. So the single suite of tools that had a common look and feel and a single database was eventually the choice. The next thing that happened was in the early 2000s, starting in around 2004, government decided to incentivize and help motivate the creation of electronic health records for all citizens. This was a huge goal, and even today, after more than 20 years, it has still not been realized, although there has been a significant amount of progress. In this early period of this, and up till about maybe 10 years ago, financial incentives were promoted by the government to enable providers, hospitals, and physician offices to adopt electronic medical record systems known as EMRs. And these incentives came under the term meaningful use, which was something that came out of Congress. The idea was you didn't just have to buy the system using the government's subsidized procurement method, but you also had to use it in a meaningful way, meaning you had to actually use it in a way that moved the needle on the quality of healthcare. And there was also a need to be able to share information with other providers and with the patients. The goal of meaningful use was a laudable one, was to enable sharing of this information in order to reduce the cost and improve quality of care by minimizing repetitive testing. Very often when a patient would go to a new doctor, even if they'd already had a suite of tests performed, because the results were not available readily, the patient would be asked to repeat the test. And of course, that introduced cost as well as inconvenience. Often also there was lack of access to the medication history of the patient. So the new provider may not even know what medications the patient was taking or had taken in the past, and also prior diagnoses. So these essential pieces of information were part of the goal of meaningful use, to be able to share this electronically from provider to provider through the internet. So data sharing really became the next focus. And it actually became a global phenomenon. I was fortunate to be working globally at this time, and governments around the world were actually investing in these longitudinal, comprehensive electronic health records, or EHRs, which would pull together a patient's health information from multiple independent providers that they had been seeing. So adoption of EMRs, and as distinct from EHR, EMR was determined to be the term that we use for the system that an individual provider's office or hospital would acquire. And an EHR, or electronic health record, was a more comprehensive set of data for a patient. So EMR is the system that the doctor uses. EHR would be the comprehensive record for a patient. So EMRs alone would not create the EHR. There was a need to be able to share this information, as I mentioned. However, during this era, the standards for sharing were immature and unreliable. So even though many providers had acquired these EMRs, they were unable to actually share the data that they were required to share. So an enormous amount of effort and expense was put into trying to rapidly mature these standards and test them based on the key workflows that meaningful use mandates required. So there was a significant collaborative effort established between standards organizations in the US and globally. And also there was oversight established from policy leaders to be able to direct those efforts and ensure that they would achieve the goals that meaningful use had set. So the thing about standards is they're boring, but they're essential. They are important because they enable predictability, meaning measurement, repeatability, reproducibility. They enable specialization. They enable more vendors to plug and play into the comprehensive EHR solution. They also prevent lock-in, so that a vendor who has a patient's data stored in their system can actually share that and not just have it locked up where it can't be accessed by other providers and other systems. And finally, they reduce costs, because when you have standards, then you can have a repeatable installation process that's not custom for each individual installation. And that was significant. So around the same time, in order to establish these EHRs, again, the comprehensive electronic health record that networked together all of these different systems across a region or across a country, many countries in the world began to establish what they called national e-health initiatives, which would network and share this data regionally or across the country, depending on the size. A lot of funding was invested in this, billions of dollars. And again, the key goal was to enable better care for patients at a lower cost. These national e-health projects were actually laboratories in a sense. They were all testing different versions of different standards for data sharing. They were employing different architectures for establishing these regional networks. And they also had struggles with different governance approaches, how to oversee these projects and ensure that they were managed properly and achieved the proper goals. There was sort of a division that established at that time between what we would call public and private networks. The public ones were funded heavily by the government, and they might, in the US, they were typically for an entire state or a county or several counties of a state. And they were nonprofits. They were independent of any established healthcare provider, such as a hospital network. Some of these did succeed. A lot of collaboration, a lot of diplomacy was needed to encourage hospitals to actually share their data and be able to import and export it through these centralized network hubs. These were called HIEs, or Health Information Exchanges. And the ones that in the end seem to have survived, although a few of the public ones are still around, some of the ones that actually gained more traction in the early years were the private networks, because these were established based on a demonstrated need by hospital organizations in a particular region who referred patients to each other or who received referrals from common sources. And they had funding, they had motivation, they had established collaboration already in place at the senior level of the organizations. And so they were able to get these up and running. And a number of them, as I said, have succeeded. They started early with simple information like medication histories, lab results, and then as the standards matured, they were able to actually export more comprehensive clinical documents out of their electronic medical records and share those as well. So what happened next was meaningful use expanded. The government decided that it was time to connect additional healthcare stakeholders into the system. And so this began to address the needs of unaddressed areas of healthcare, such as behavioral health or mental health, long-term care, pharmacies, etc., which had been left out of the early incentives and didn't have access to these HIEs or health information exchanges. So they were now included. They were now offered incentives, financial incentives to participate, and the richness of the data available through those networks grew significantly. At the same time, the vendors of the electronic medical records were being besieged with requests for connectivity because of these networks being established within the hospitals and also between hospitals. They were being asked, how can we plug into the electronic medical record and put data in there or take data out of it? So a big focus was on application programming interfaces, or APIs, and app farms, which were developed to enable other vendors to be able to participate and connect into the EMR. So point to be made here is that the electronic medical record is today the core of the health IT system in almost any healthcare provider organization. It is the largest investment that they've made. It is almost always a 7-figure plus investment, sometimes more than that, sometimes 8 figures. So it is actually quite a significant thing, and they want to optimize that. So again, in parallel with this, standards which would enable these connections through the APIs, the app farms, and others were developed. And the most recent set of standards which we're seeing in the marketplace now is from an organization called HL7, Health Level 7. It's been around for decades. Interfacing in the past was always done using their version 2. They had kind of a false start with version 3, which never really took off. And now they have something called FHIR, FHIR. I believe that stands for Fast Healthcare Interfacing Resource. And those standards have really taken off, and they are now being adopted and promoted aggressively into the commercial marketplace. So as far as enabling healthcare transformation, really, as I mentioned, the electronic medical record is still the core and foundation of the digitization of healthcare in healthcare provider organizations. And it's evolving from, there's stages of it. There's really 5 stages we can identify of sophistication. So the EMR vendors themselves have invested heavily over the years in advancing the capabilities and of their system. And I'll talk in a minute about the technologies that are being added. But the big picture is that they started off as simple dumb databases that collected information. Then they went into automated documentation of interactions with patients and with labs, etc. Then the next generation has clinical decision support, which is an AI type of a solution which would enable the EMR to become a helper, sort of a helper that would give reminders to the clinician. If a patient has this diagnosis or this symptom, maybe this test is indicated, or maybe this diagnosis is indicated. Then the next level would be the EMR becomes a colleague, where it actually can support the workflow as an equal partner with the physician. And then the holy grail, which has not been achieved, is what you would call guided care, where the EMR actually would become a mentor and actually oversee the whole process and ensure the standard of care is being met. This, of course, does introduce some ethical and legal issues. I wrote a column on this a number of years ago about the legal liability that EMR vendors could eventually be subject to if the physician relies on it in lieu of their own training. Because as we know, when doctors leave medical school, medical knowledge is doubling every 8 years, and maybe even more rapidly these days. But it comes to a point where the computer may actually have more up-to-date and more complete information than the physician themselves. And so who's responsible if the physician relies on the computer's updated information to make a diagnosis and recommend a treatment plan? This introduces issues that have to be addressed. So the standard today is that if there is a physician between the computer and the patient, the physician bears ultimate responsibility and decision making for that treatment plan. So, there's a lot of moving parts here. There's a lot of things that are going to develop over the coming years. And what we're seeing now is additional technologies emerging, which are supporting the whole workflow and in-hospital and intra-hospital and intra-physician office and ambulatory surgical centers. All of these different sites of care are being connected, and more types of communication technologies are being used. And all of these are intended to again, increase the quality of care at lower cost. And these are things like other speakers have talked about: AI, artificial intelligence, natural language processing, or NLP, where the physician can simply speak and the computer understands and records everything. They can even parse those spoken comments into structured data, which can then be reported. There's obviously a heavy emphasis on mobile enablement of any health IT system. Most care providers it's not compatible with their workflows to sit in front of a computer screen and not interact directly with patients or be walking around the floors or from one floor to another. So they want everything to be also accessible on mobile devices. Another huge trend that we're seeing in healthcare, and it's moving rapidly, is the move to cloud. and especially cloud native applications where particularly for smaller institutions that don't have large IT staffs or in-house data centers, they can just use software as a service through the cloud, and they can pay on a subscription basis rather than have to invest huge amounts of their precious capital into acquiring a system. There are trends such as platform as a service, which is where multiple applications can share the same common architecture and platform and grow as the needs of the organization grow. Of course, clinical decision support. And then one which I was recently involved with in my last board position, clinical communication and collaboration, which is a very exciting area which enables care teams to collaborate with each other in real time about the care of a patient with reference to the recorded clinical history of the patient in the EMR and also the EHR. The sort of payment and legal structures that support the introduction of these tools and of these enablement of these goals of saving money and delivering better care, you'll hear terms now such as value-based care. In the past, before all this digital healthcare technology was available, everything was fee for service, and there's still a lot of it around. Basically, whatever the doctor does, they get paid for based on the time and materials. Essentially, it's like when you bid on somebody as a contractor, they can either do a bid or time and materials. So in the past, doctors have always been sort of time and materials fee-based. Nowadays, value-based care, which is considering things like the outcome, did the patient get better? How much did it cost, et cetera? All of that factors into the compensation that provider organizations and their physicians receive. And also the government has incentivized the establishment of what they call accountable care organizations, or ACOs. That's another alphabet soup here. But this is another attempt to get providers to pay attention to the cost and quality of care and get reimbursed accordingly. So technologies, applications, and the players in this marketplace are going to continue to evolve as they have been. Many of them will merge as shakeouts occur in the marketplace. We've seen, for example, in the EMR marketplace a few years ago, there were literally hundreds of EMR vendors that came on the scene with the availability of huge amounts of government money and meaningful use incentives. On the large end of the scale, it's really shaken out to only 3 or 4 vendors that pretty much own the marketplace. So the same thing continues. It has always continued. It happened in the imaging space, and it will happen more. But the goals do not change. And again, it's better care at lower cost. So with that, I will pause and come back to where I can see you and see if anybody has any questions.
Blair, thank you so much. That was great. And thank you for, I always appreciate when someone doesn't have to, be reading off a slide or just, I think there's just a different level, of expertise, when you're able just to kind of go off the hook cuff like that. So I appreciate that. So let's see. I'm looking to see if we have any questions from the audience so far. We do not yet. If you have any questions for Blair, please drop them in the comments. Blair, so while we wait for some questions to come in, let me ask you a few things. First off, where can people connect with you offline?
Sure. I'm on LinkedIn, so you can find me there, and also on email. You can get me through my organization. Just email info@windriveradvisorygroup.com.
Amazing.
Yeah.
I will have the mods share that information. If not, people can just reach out to you on LinkedIn and get your information that way as well. It looks like we have a question from Andrew. Andrew asked, how many fast healthcare interoperability resources have you had?
Yeah, that's a great question. I'm not in the weeds of the actual standards world as much as I used to be. I know that it is a significant effort. I know that the Office of the National Coordinator of Health IT, which is a government funded position of the federal government, it's part of the Department of Health, um, is very engaged in this as well. And it's HL7. So if you go to hl7.org, I believe is their website. You should be able to find out a lot about it there. But this is sort of the latest frontier of standards convergence and simplification, because frankly, it had gotten way too complex in the past. And the ability to, back in the day when I was involved with these actual systems going in, the establishing interfaces between them was a double-edged sword. It was for the vendors. Number one, it made every installation custom and individual and different. And the comment you'd always hear is, if you've seen one HL7 interface, you've seen one HL7 interface, because each one was different. On the other hand, once it was established, the customer really didn't want to go through the effort and expense to replace it. And so as long as your system was working, they weren't going to replace you anytime soon, and you'd keep collecting the annual support contract, et cetera. So all of that's disappearing now with these new standards. It's much easier to replace a vendor, especially with cloud native systems in place. People can just turn off a subscription and turn on another one somewhere else. It's not quite that simple, but it is a lot simpler than it used to be. And that's good. I think it creates more competition. People have to deliver. They can't just get complacent and assume that it's too hard for the customer to change vendors, and therefore they're set. So that's progress in my view.
Thank you, Andrew, for that question. Thank you, Blair, for your answer. So let's see. Not any more questions. I have a few questions for you I like to personally ask. So first off, what are your predictions in 2023? Or at least one prediction that you have based on I guess anything
Mhm.
that you have to do with and that you're working on. Like, what's the prediction that you can share with us?
Yeah, I think it's everyone's talking about artificial intelligence now, and that's sort of a big frontier that's being addressed. It's a huge subject. It's complicated. As some of your other speakers who are actually involved with companies that do AI are probably better qualified than me to talk about those fine details. But there's that, and then there's just a continued need to harvest results from these huge investments in these EMRs. And with the sort of slowdown in the economy, I think what we're going to see is probably less innovative sort of blue sky technologies being launched and tested, and more of a sort of retrenching and saying, how can we squeeze more value out of the investment we've already made, making sort of smaller incremental adjustments and additions that will allow the goal, of cost saving to be achieved. So it's sort of a trade-off, invest a little to save a lot. That's going to be sort of the mantra, I think, that we're going to hear a lot from CIOs and others going forward.
Yeah, it's really interesting that you say that, because I agree. I think, part of, whether you're a new startup or, a startup that's been around for a few years, I think we do a really good job of like scaling quickly, but not really maximizing, like all the juice, for
Mhm.
better lack of terms. So I think, companies, are going to need to get innovative about how they become more efficient in order to, kind of stay alive, especially with what we're seeing as, you know, even though there's a lot of news about VCs and funding being kind of held back, there's still a lot of companies that are VCs and funds that are investing in startups. So I think, something that you mentioned earlier in your conversation, I thought was really interesting about healthcare, how a lot of these, um, online or telehealth or, just virtual health companies are moving to more of a value based approach.
Mhm.
And kind of, for me, I run an accelerator program here in Dallas, and we always talk about like selling the benefits and not the features, and that's kind of where
Right.
I see value based kind of playing a role. So I know of one company I've worked in the past out in Silicon Valley, and that's the first time I ever heard of that kind of terminology. So I thought it really fascinated by that. So I really appreciate you sharing all that insight. It doesn't look like we have any more questions. So I don't know if you have any last parting words or any advice or anything you'd like to say to the audience.
Just, health IT is an exciting area to be in with a career, and it has a very long and bright future. And certainly it did well for me, and I would encourage those of you that might be considering it. And you can also do good for people at the same time, of course, helping develop solutions to intractable healthcare problems. We all know that healthcare is one of the largest parts of the national budget. It sucks up a huge amount of money in this country that could otherwise be used. And if people could have better health and more productive lives, then that strengthens the overall economy. So health IT is kind of a fundamental enabler, as IT is in almost any industry, but healthcare has lagged behind. Because it is such a complex industry. There are so many barriers to entry, as was mentioned by other speakers. But those that are persisting and that have been in it a long time and understand the challenges and how to solve them, um, we just can't appreciate enough what's being done today. So anyway, thank you all for your attention and your time. It was a pleasure to be here, and I look forward to hearing the rest of it.
Thank you, Blair. I hope you have a great day.
Thank
Stay
you.
warm. I know it's not that. It doesn't look that. It looks a lot warmer than it probably is.
Yes,
So
exactly. It's all white now. So thank you.
cool. Yep, absolutely. Have a great one. Thanks for joining us.
Sure. Bye bye.